Welcome to RUMC Vital Signs. My name is Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit www.rumcsi.org. According to the Centers for Disease Control and Prevention, over 38 million Americans have diabetes, a chronic disease that occurs either when the pancreas does not produce enough insulin or when the body cannot effectively use the insulin it produces. Over 1.8 million adults in New York State, or just over 11% of the state's adult population, have been diagnosed with diabetes. And every year, an estimated 92,000 more adults in New York State will be diagnosed with diabetes. Here to discuss these alarming trends, their possible causes, and the latest treatments is Dr. Philip Otterbeck. Thanks for joining us, Dr. Otterbeck.
My pleasure.
Dr. Otterbeck is a board-certified endocrinologist, chief of endocrinology at Richmond University Medical Center, and chair of the hospital's Department of Medicine. So let me start by asking you, if the numbers are rising across the country and across the state, I have to believe the numbers here on Staten Island are rising as well. Is that true? And if it is, what do you think are the reasons?
No, thank you, Alex. You know, it's exactly true. The number of people with diabetes has continued to increase year over year, and the reasons for that are multifold. There are cultural reasons, societal reasons. We're not exercising as much as we used to. We lead a very sedentary lifestyle. A lot of our life is centered around our devices, our telephones, television. Children aren't going out and playing basketball as much as they used to, and so a lot of our focus has been away from the physical activities and more toward the sedentary ones. But in addition to that, our diets over the years have deteriorated, and we can see certainly the number of people that struggle with being overweight or obese has increased. And there's a very close relationship between being overweight and obese and the development of diabetes. So, so for a variety of reasons, some are modifiable, some are not. Nevertheless, in totality, the number of folks with diabetes, in particular in Staten Island, has increased. We're up to about 10% of the island with diabetes. 95% of that is type 2 diabetes, and about 5% is type 1. And those numbers, unfortunately, continue to increase, as you mentioned.
Can you explain a little bit the difference between the two types and what are the symptoms?
Yeah. So ideally, diabetes should be caught when it's asymptomatic, meaning patients don't have any symptoms yet, and that can be identified with a simple blood test. But we distinguish between the two types of diabetes into two large buckets, type 1 and type 2. Type 1 is what we've always traditionally thought as a disease presenting in youth, an autoimmune process. And what does it mean, autoimmune? It's where the body attacks itself. And the body attacks the beta cells of the pancreas, and the pancreas is the organ in our body that produces insulin. And when you make the pancreas unable to make insulin, the patients are unable to control their blood sugar. And they develop, therefore, diabetes. And those are the types of patients that are dependent upon insulin for the rest of their lives. Type 2 diabetes, we've always thought of as it's a disease of as you get older. You gain weight, you get medical problems, you wind up on some medications which raise your blood sugar, whatever. That group of things results in this condition of type 2 diabetes where you're unable to make enough insulin to meet your body's needs to control your blood sugar. What's happened, however, unfortunately over the years is there's some overlap now between the age ranges that we used to think of as a separation of the two disease states. Younger and younger of people are starting to get type 2 diabetes because of what we mentioned to a little while ago, which is the change in activity levels as well as the obesity rates.
So what is that link between obesity and diabetes?
When you are obese or overweight, what happens is you become insulin resistant. What does it mean? It means if you have one patient who's insulin sensitive and another patient that is insulin resistant, say they both eat the same cupcake. One person will have to make 2 units of insulin to control his or her blood sugar. The other one will have to make 5. The one that has to make 5 is what they call insulin resistant. You need more insulin to control your blood sugar. Now, over time, what happens is that insulin resistance burns out the pancreas. The pancreas struggles to make enough insulin, and over time weakens and weakens, and ultimately can't keep up with the body's needs, and thus the sugar rises and people become the sugar rises and they become diabetic.
So is it possible to lose weight or say have bariatric surgery and I'll say reverse the diabetic condition?
I don't want to say the word reverse.
Okay.
It's kind of a loaded term. What it can do is it can manage the diabetes.
Okay.
So diabetes is one of those things, once you have it, it doesn't go away no matter what you do. You can do diet, exercise, it's not going to go away, but you can manage it well with diet and exercise modification, plus or minus medications, and as you alluded to, plus or minus bariatric surgery. Bariatric surgery, because of its effect on weight, dramatically lowers the blood sugar, and in many of the cases that I've dealt with bariatric surgery patients, those individuals are actually able to come off almost all of their diabetes medications because of the effect of the surgery. But additionally, if patients are able to do diet and exercise modification, certainly they can wind up on 2 or 3 or 4 or 5 medications, but if they significantly change their diet, you can certainly decrease the number of medications and in some cases stop the medications, and they'll be very well managed just on diet and exercise alone.
Wow. When you talk about seeing younger people being diagnosed with diabetes, is there a particular age range that you're seeing it? Is it teenagers, preteens?
So I'm an adult endocrinologist. Nevertheless, my colleagues in the pediatric space, pediatric endocrinology, they are seeing it as early as 10, 11, 12.
Wow.
And you can certainly see the among the children, the weight gain that they have, but also if when you might notice on some children they have a little bit of darkening in the skin in the fold of their neck. They call this acanthosis nigricans as a reflection of insulin resistance, this concept of progression of high blood sugar or hyperglycemia. And the other thing to look out for with children, not just children but also adults, is they tend to get little skin tags on their neck or under their arm. Those can be signs of insulin resistance and the approaching of diabetes.
Wow. And I know, as you said, you're an adult endocrinologist, but another question just about kids. Is there a connection? Do the parents tend to be diabetic and then the child becomes diabetic?
So the short answer is yes, and then the question is why? Well, there's multiple reasons. One is genetic factors, right? And the predisposition to diabetes tends to be most potent from the maternal side. So if mom has diabetes, the child is much more likely to get type 2 diabetes as compared to, say, if we're on dad's side. So that's one part. So a genetic predisposition is certainly there. But also what happens is families tend to eat the same foods and the same style of foods. So if that dietary approach has resulted in diabetes in one generation, almost certainly it's going to certainly increase the risk for diabetes development in the younger generation. So it's very important for patients to look at that and say, look, we can all do this together. You know, if we have an adult in the family, mom or dad, that has diabetes, what you do for the mom or dad to control their blood sugar, you should have the same diet for the children, because it's essential that those children, certainly in the course of their lives, are going to be at risk. And so a diet plan for one generation can help all the generations in the family.
And I remember a couple episodes back, we had Dr. Barkin on, who is in charge of our bariatric program, bariatric surgery, and he stressed that recently and more commonly now we are seeing obesity in young children more than before. So there, I guess, is that tied, a stat that we were looking at when we were preparing for the show. So according to the CDC, 53% of new cases of type 2 diabetes that will be diagnosed this year are linked to obesity.
That's right, and even more disturbingly, in addition to that, if you look at all the people that have type 2 diabetes, 90% are either overweight or obese. So if you keep yourself out of that group, you know the chance of diabetes certainly are much less.
And there's also a condition that's called pre-diabetes.
Yeah.
What is that?
So pre-diabetes is being on your way to developing diabetes. If you look at the lifetime risk of developing diabetes, overt clinical disease in a patient. If they have prediabetes, the risk of lifetime getting it is 50%. And it's about 5 to 10% of patients per year that are pre-diabetic will move to diabetes. So it's a preclinical state. It's diagnosed by a blood test, and the A1C, A1C is a 3-month blood sugar number. It assesses how a person's level of control for 3 months. that A1C would fall anywhere from 5.7 to 6.4. Diabetes is diagnosed at 6.5.
Okay.
If you go by the fasting blood sugar, which is, you go to the doctor, get your blood test done, your fasting sugar for pre-diabetes would be between 100 and 125. If it's 126 or above on 2 occasions, that's consistent with diabetes.
So you can be pre-diabetic, but it doesn't necessarily mean you're going to graduate to diabetes?
Doesn't mean you're going to necessarily get there. Half of people do. But with good diet and exercise modification, it doesn't need to happen. So we don't have to think of it as a fait accompli. We'll say it is not. It's just that people have to really intervene. So the idea of pre-diabetes should be not just to say, okay, the number is the number. It should be a call to action to say, okay, I really need to make a change in my lifestyle now to prevent what could come in the future.
So you talked about the A1C, which I think a lot of people know about. You said it's 3 months. And someone might think, well, if it's going to be a 3-month window into, should I not have my A1C done? That includes, say, the month of November and December, because those are holidays. Does that impact the A1C or no?
Sure. I mean,
is there like a perfect time to do an A1C?
No. I mean, I have a lot of patients that strategize when they're going to do their blood test, when they're going to come see me. And it's probably not the right approach. Because you know what happens? People that strategize around the holiday, Thanksgiving, Christmas, Hanukkah, all these things that are around that winter time. But it's not as if we don't have holidays other times of the year, right? Then we have Passover and Easter, and then you have the 4th of July. And there's always an excuse throughout the year to not be doing what you're supposed to do. So the answer is do your blood test when you're supposed to. But it is absolutely true that particularly from November to December, right, where you have Thanksgiving and Christmas, people turn their dietary indiscretions into a holiday season. I always say, look, if you want to have a great time on Thanksgiving, enjoy yourself, have a good time on Thanksgiving. But Thanksgiving can't be, Thanksgiving and then the Friday, Saturday, Sunday you're eating leftovers, and then you start, putting up the Christmas tree and having Christmas cookies, right? So the idea is we have to. I'm not saying to have a perfect diet, but you have to have a good diet the vast majority of the time, and then it'll give you the opportunity to cheat with family and friends when you feel like you need to.
And if someone is diagnosed, how is diabetes treated and managed?
The base of it is diet and exercise modification. Unfortunately, those are the hardest to do, right? There's only one part of diet and exercise, there's only one part of diabetes management the doctor controls, and that's the medicines we give. Right. The rest of it is on the patient. Right. And they should be working as much as they can to exercise as much as they can, 30 minutes of exercise. Moderate exercise, 3-4 times a week is enough in most cases. Restricting carbohydrate consumption, having lean meats, chicken, turkey, fish, like those types of foods, and green vegetables, right? So the vegetable isn't a potato, right? The vegetable is string beans, broccoli rabe, escarole. These kinds of foods are the base of our diabetes management. Now, beyond that, there are medications, and there are a lot of them. There's oral agents, injectable agents. I'm sure most of the audience knows the medicine metformin, which is really, according to all the guidelines, that's still the base of our diabetes management. And then beyond that, there are, I always talk about it as in terms of having a toolbox, and that toolbox is getting bigger and bigger. But there are a lot of exciting therapies that are on the market, and I know there's lots of TV commercials that my patients are watching and coming in and asking about those medications.
So if metformin is, and for full disclosure to the audience, I myself am type 2 diabetic, take metformin. Dr. Otterbeck is my endocrinologist, so thank you for all that you do for me. What exactly does metformin do that it is the base of the medication?
Well, it's a base of the medication for a variety of reasons. One is it's been around for decades. It's safe. It's pretty cheap. So of course insurance companies like, but also well tolerated, and it's an efficacious approach to management. What it does. So our liver, one of its jobs is to make glucose when we're not eating. So all of us overnight, we don't usually eat. So if we didn't have our liver keeping our sugar up, we would all die. So they call that gluconeogenesis, making sugar from other parts. Now the problem is that when you have diabetes, when a person has diabetes, the liver loses its ability to sense whether sugar is high or low. So what the liver does is keep making more and more and more sugar, despite the fact that the sugar is already high. And what metformin does is it reorients the liver to the fact, and it basically says to the liver, look, sugar's already high, stop making so much. And it turns off that excess glucose production.
So it's like a sugar policeman.
Exactly.
Okay.
Yes.
Okay. And as you alluded to, there's these commercials for Ozempic and Rybelsus. What are these medications? And I know a lot of people are looking at them as weight loss drugs. But what exactly are these new line of drugs? How do they attack diabetes, and what are their benefits, and what are their side effects, if any?
Yeah. So these drugs have been out and have been in trials actually for at least 20 years. I mean, I've been using not these particular drugs, but their cousins. The first drug of this class that was released was called Byetta, and it was a twice-daily injection. Now we've got Ozempic, which is a once-weekly medication. And the base of this drug is what's called, the chemical name of this is semaglutide. And semaglutide is basically an analog of a hormone that our body makes called GLP-1. Okay. And GLP-1, what it does is it makes your pancreas work better and make more insulin. It turns off another hormone, another glucose-making hormone from the pancreas called glucagon. And also, it binds to receptors in the brain in an area called the hypothalamus, which is the appetite center. It suppresses the appetite. So you can imagine, when appetite is suppressed, patients eat less. So they lose weight, sugar improves by those other mechanisms that I talked about, as well as by less consumption, and sugars improve and people lose weight. So we've found them very efficacious for weight loss, and thus we've seen a lot of we've seen a lot of social media surrounding the medications, celebrities taking them, and they are clinically efficacious for weight loss. So they have, so each of them, Ozempic being one of them, the semaglutide has two versions. The diabetes version, which is Ozempic, and Wegovy, which is the weight loss, the drug that's approved for weight loss. They're exactly the same drug, just in a different container. One's approved for diabetes, one's approved for weight loss. And then the other one that's very popular right now is called Mounjaro, and that is called tirzepatide is the chemical name. And it's, I don't even want to say cousin because it's not a cousin, it's a twin. Its twin is called Zepbound. Again, exactly the same medicine, one approved for diabetes, one approved for weight loss. And they work by the mechanism that I discussed and are highly efficacious for weight loss as well as sugar control.
Well, half the names you mentioned, the brand names sound a lot easier to say than what they actually are. So and one of the things you had shared also is that these drugs like Ozempic also have a cardiovascular benefit.
Yes. And we also wanted to just mention briefly the side effects. So in some patients, the side effect profile it binds, we talked about them binding to the hypothalamic receptors in the brain. And some people that results in satiety, that they don't feel like eating. But in some people, it causes nausea, vomiting, stomach upset. In some patients, it causes diarrhea. Some people it causes constipation. So if you start the drug and you're experiencing some of those side effects, it's important to let the doctor know. And then in terms of cardiovascular benefit, if you are a patient that has diabetes and has simultaneously a stent or a bypass or one of those things, or history of stroke or peripheral vascular disease that has blockages in the lower extremities, it is important that you would take something like Ozempic or some of the others for cardiovascular protection. So it has benefit for the patient independent of its effect on hemoglobin A1C or the blood sugar. So the current most recent recommendations from the American Diabetes Association, ACE, which is the American Association of Clinical Endocrinologists, recommends initiating these therapies whether or not the patient is at their A1C target, because of its separate and distinct effect on the cardiovascular system.
Wow, it's almost, I don't want to say super drug, but it sounds like it's got so many multifaceted benefits. It sounds really good, I guess.
Yeah.
So we talked about how you manage it, so let's kind of go the other end. What happens, what are some of the complications if diabetes is left untreated?
We divide the untreated complications into two groups. We call them macrovascular complications and microvascular complications. So let's talk about the microvascular complications first. Those are retinopathy, damage to the back of the eye, neuropathy, damage to the the nervous system, as well as nephropathy, which is damage to the kidneys. So all those can be affected by diabetes, and if you improve diabetes control, it mitigates those risks. Second group is the macrovascular complications. So heart attack, the big vessels, right? The vessels in the brain, stroke, and the vessels in the lower extremities, peripheral vascular disease. So all of these are, so if you think about it really, diabetes is affecting patients quite literally from head to toe. And uncontrolled diabetes will cause problems from head to toe. And if you control the diabetes, you'll decrease the amount of those complications and the severity of those complications.
And you talked about the diet that you recommend for people to follow who have diabetes, and we've had cardiologists on and many, and they all seem it's that same kind of diet: leafy greens, vegetables, and fruits, and I'm guessing that's kind of the lean meats. So I guess it's really fat reduction is what we're talking about, and obviously sugary stuff as well.
I'll maybe give you a slightly different spin on it. Diet is a very controversial topic. And there are folks out there that are pushing plant-only approaches to diet. There are people that are talking about low-carb diets. So everybody's got a different spin on it.
The Mediterranean diet.
Mediterranean diet. And I always say, you know, if you go to the bookstore into the diet section, you know, anybody that still goes to a bookstore, I don't know if people do that anymore, but if you go, there's a whole shelf of those books. And the question is, does anybody have the answer? And the answer is probably not. So what is the right diet? Well, I always say the right diet is the one you can stay on. So if you find the one that you can stay on and do consistently for the rest of your life, that's the diet that you should stay on to manage diabetes. Because it does not make sense to do something, anybody can do something for a month or 2 or 3 or 6 and lose weight and do well with the sugar. The point is, what is sustainable forever?
Right.
And if you can't say, when you look at a diet program and you can't say I can see myself on that 10 years from now, don't do it.
Don't do it.
It's not worth it.
There's a lot of myths out there about diabetes. You've cleared up a lot of them today, but I wanted to ask you a couple of quick questions as kind of a yes or no lightning round. And obviously, please feel free to elaborate. So, the first one is, if a person is overweight, they will always develop type 2 diabetes?
No, not everybody who's overweight. I mean, we have very severely obese patients that happen to not have the genetic setup for diabetes. So they, you know, it's not good to be that overweight for a variety of different reasons, but in that particular patient's genetic makeup, it does not predispose them to a glucose problem. So.
Another one is, sugary drinks cause diabetes?
Yes and no. Depends. You know, if you have 1 or twice a year, it's certainly not going to cause you to have diabetes. But if it's a consistent approach, if you're having, you know, soda or 2 a day, particularly regular soda, it certainly can increase your risk pretty significantly for developing diabetes.
People with diabetes, it's not safe for them to exercise?
There are very few patients where I would say it's unsafe for them to exercise. Those are truly very advanced disease, those would be very advanced cardiovascular disease, where the doctor would say, listen, and those would typically be people really at the end of life. The vast, vast majority of patients can exercise. Now, they might have other limitations. I mean, some of my patients are quite overweight, they've been so for some time, and their knees hurt. And they tell me, Doc, I can't walk. I certainly can't run, and I can barely walk. I tell them, look, I understand that, and I'm not going to, you know, ask you to run around the block for that severe pain. But there's a few things. One is you have to, if you can't exercise, you can't burn the calories, fewer calories have to go in. So that patient really has to focus on what they're consuming. But also, even as they're sitting there, if they're watching TV or whatever, I tell them to get 2 or 3 pound weights and do things with their arms. Unless they've concomitantly got an arm problem, they can still do something a little bit with exercise and achieve some benefit.
Diabetics can't eat candy or other sweets and need to stay away from carbs?
Generally, they should avoid carbs, but no one is perfect. I'm not. I don't know if you are, Alex, but I know I'm not. And I don't ask my patients to be, because people can be perfect for a small amount of time, and they can't be perfect all of the time forever. So what they should do, have fewer of those things, cut back on the consumption of carbohydrates, come back on the consumption of candy and all of these other things, so that when you really do feel like having something, you have a little piece, or have a share of it, but not every day, shouldn't be every week.
And then lastly, diabetics are more likely to catch colds and other illnesses.
Diabetes increases your risk. It impedes the efficacy of the immune system. So yes, there's ample data to show that infection rates, both from the standpoint of something like pneumonia, sadly recently we saw with COVID, people with diabetes did worse than people that didn't have diabetes. And I'm sure the audience is familiar with people that develop diabetic foot infections. These can, they're all increased risk for these diseases when a patient has diabetes.
Well, I'm going to let you have the last word. What can Staten Islanders do to keep the upper hand on diabetes?
Keep moving, keep exercising as much as conceivable. I know time is tight, but people's got to find time in their day to spend 30 minutes a few times a week doing some type of physical activity. And it doesn't have to be activity that they find to be bothersome. They can go to the park. Staten Island, we have, I think, a third of the Staten Island is parkland, right? So borough of parks, and we can, there's parks all over the island that are nice and green and really there for our enjoyment. So take the family out, do it together, because it'll help not only the patient, but it'll also help the family members. And lastly, and dietary consumption. Please try to avoid the bread, pasta, rice, all of these things that have a tendency, very high glycemic index, tendency to raise blood sugar. Avoid juices and soda. These are the things that consumed in large quantities really can impact people's chances of getting diabetes.
Well, I want to thank you for coming on today and enlightening us all about diabetes, and thanks for taking care of Staten Island. Dr. Otterbeck is a native Staten Islander, so and has offices on Victory Boulevard. If you'd like to contact Dr. Otterbeck for an appointment, his office is located at 1366 Victory Boulevard, right here on Staten Island. The office number is 718-727-1366. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for nearly 120 years. You can help ensure that care continues by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the donate button located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.